Hello and welcome to Connected with Latham, where we discuss ideas, legal developments, and business trends shaping the global economy. This is the 10th episode of the Latham & Watkins Drug Pricing Series, and I'm Chris Schott, a partner in the healthcare and life sciences practice in our Washington, D.C. office. I focus my practice on all things market access, and that includes manufacturer compliance related to the Medicaid drug rebate program, Medicare, and the 340B drug pricing program, as well as, of course, implementation of the Inflation Reduction Act. Joining me is Daniel Machado, an associate in our Washington, D.C. office.
Hey, Chris. Awesome to be here for another great discussion.
And we have a guest on our podcast today, and we are very happy and fortunate to welcome Amanda Forys from Magnolia Market Access.
Hi, Chris. Thank you so much for having me today. My name is Amanda Forys. I'm the managing partner at Magnolia Market Access. Our firm consults on policy, market access, and health economics issues. And thanks for having me, as I know the IRA has been a huge focus for you and for us the past few years. So I'm excited to talk about it today.
Thank you, and thank you for joining the podcast today. In each episode, we focus on a specific topic that is relevant to drug pricing or the pharmaceutical industry or the healthcare industry. And after discussing the substance, we ask the question, which Olympic sport is it like? And we have the list of Olympic sports here to see which most resembles the topic in terms of strategy, complexity, or frankly, level of conflict. So we've been going with this Olympic sport theme since the inception of the podcast, but of course this month it's particularly topical with the Olympic Games actually in progress in Paris. So Danny, what is our topic for today?
Yeah, thanks, Chris. So on our podcast, we've obviously discussed the Inflation Reduction Act or the IRA in various contexts in previous episodes. But today we want to focus on a different angle, and that is how payers or health insurance companies are reacting to the IRA. And we're lucky to have Amanda here with us today to share some of interesting insights from her work. Amanda, over to you.
Great. Thanks, Danny. So yes, our company, as soon as the IRA passed, we had a lot of our clients asking us what they thought the future of the Part D program would be and how they should start preparing for it. So the first thing we did was we decided to set up a payer survey. Over the past 2 years, we've completed 4 rounds of it. We actually just wrapped up our last one and delivered it to our clients last week. And what we tried to do during each survey is get insights on kind of the main provisions of the IRA, including the drug price negotiation program, the Part D redesign, the what we're calling smoothing, the Medicare prescription payment program or M3P, and then really just get a sense of broader implications of the law and how it will affect not just the Medicare market, but spill over into other markets as well. So each time we've tried to kind of hit up on something new that's come out. So for example, back in the fall when we did our survey, we really dug into some of the drug price negotiation because the list had just come out. This last one that we did, we got a lot of thoughts from the payers on the smoothing plan and what they were doing and planning to do in 2025 with their formulary designs as they're going through that process with CMS right now and how they're thinking about the future of their plans as the IRA unfolds.
Yeah, and I think it's really interesting to kind of review what the survey results were, and I think there's a public version of that available on the Magnolia website, which we'll have a link to that in the notes to the podcast. It's really helpful for us because we focus on the manufacturer side of things, and hugely helpful to kind of see insight from another key stakeholder on how they're implementing these new provisions. So the first topic, I think, is going to be the price negotiation, just maybe by brief introduction. Out of all the parts of the IRA, this is the one drawing the most attention because it's such a big paradigm shift in how the federal programs have paid for drugs. Traditionally, we've had the free market model where manufacturers report their pricing and the government sets reimbursement and other metrics based on market as reported by manufacturers. And of course, the IRA negotiation piece is a step away from that in the direction of a more European model, where now the government is actually negotiating and, let's say it as it is, setting the price. So in terms of where we are with the implementation of this new provision, the negotiation period has just ended. We're recording here at the beginning of August, so negotiations are officially over. And now CMS has until September 1st to publish the prices for the first 10 drugs that were subject to this. And so we're all staying tuned to see what those prices will look like and when CMS will actually decide to publish. So, Amanda, in terms of this price negotiation piece, how are payers thinking about this topic? What are some trends that you learned from the survey?
Thanks, Chris. Yeah, so during the survey, one of the first things that we wanted to ask the plans was what they're doing this year and then what they plan to do in the future. Because obviously, right now, they know the plan isn't starting until 2026, but they definitely know what the drugs are. And we wanted to see if they were going to be pressing on the manufacturers early to try to benefit from the fact that an MFP was going to be released. A lot of the plans told us that this year is really just more of the normal for them, the normal processes. They didn't really go too crazy into those negotiations and are kind of waiting to see where those fair prices land in terms of what they're going to end up being paid for the drug or how they'll be paying for the drugs with manufacturers. So, what we're seeing from them is just that they plan on this adding a lot of dynamics into the system. So, I don't think you're going to really see anything majorly different as a result of negotiation in terms of the fact that payers are adding step therapy or adding, prior authorizations or doing anything really in that sense that's new or unique. A lot of them are already so engrossed in those types of tactics to manage formularies that we're going to see more of the same of that. So I wouldn't say there's some crazy new thing that the plans are going to just start implementing as a result of the negotiated prices. But what we are seeing is their reaction to that is kind of threefold. The first thing is they're going to be thinking about skinnying formularies down. So not necessarily covering all of the same drugs. Of course, they'll have to cover the drugs that were subject to the negotiation. But while the law did not necessarily say you have to cover it without steps or you have to give patients open access to those drugs, CMS has said, we're watching you, right? We're going to see how this plays out, but we want these drugs to have open access. Until CMS, drops the hammer on that, I think plans are going to do all that they can to make sure that to them, they're getting the product to the patient that nets for them the most revenue. So that is definitely a tactic of what they're going to do with formularies, what they're going to do with exclusion lists, and how they're going to handle that. The next kind of arm of this and way I think they're going to go is how they're going to handle rebates from now on. So you're already going to see, and in the survey, we learned that a good number of the plans actually think that their current negotiated prices are better than the MFP prices. So if MFP comes out, they're of course going to go to the manufacturers and say, we want you making up that delta and kind of keeping us where we're at or better. But they're also going to go to these the other competitor products and do a much more detailed dive into those contract negotiations and try to use the MFP to leverage competitor products. And we're already kind of preparing for that. And then we're also preparing for the third arm here is what's going to happen in the commercial market. So a huge number of payers that we've spoken with have said, yes, we plan on using and leveraging these prices in the commercial market. It's going to help us kind of make up for our losses and where we're going to land with the MFP if there is a loss, but we definitely plan on using this in the future. So I think those are kind of the big things that we should expect to see in 2026. I do think the list will be out very soon. I don't think we're going to be waiting till September 1. And I think just the payers and they're going to be circling the wagons and calling the manufacturers for contract negotiations as soon as it's out.
Yeah, and I think this is really the big milestone we're waiting for is the publication of these prices. This big question you raised, will there be spillover on the commercial side? What will that look like? I think we'll have a lot of those answers here shortly. Maybe by the time you're hearing this podcast, the publication will have already occurred. Let's also not lose sight of the fact that there's also obviously some litigation going on, challenges to the negotiation provision, not least of which the fact that we are forced to refer to it as the maximum fair price, which various entities have alleged is a violation of our constitutional rights because we're being forced to call this a maximum fair price. And as you know, Latham is involved in handling the litigation for one of those companies. Danny, do you want to talk a little bit about the Part D redesign?
Yeah, no, I thought that Amanda's discussion about the negotiation piece was very interesting. And yes, I think it would be great to shift a little bit to the Part D redesign. And as our listeners know, the Part D redesign, one of the other components of the IRA, it's essentially a complex set of cost shifting. The goal is to help Medicare Part D beneficiaries better afford their Part D drugs. And a couple of things that this does is that it adds a maximum out-of-pocket spending cap of $2,000 for beneficiaries. That's in 2025. After that, it's indexed to inflation, of course. And it creates two phases of coverage, the initial, the catastrophic phase. And so the old coverage gap that was created under the Affordable Care Act that had like that donut hole that we are all quite familiar with is now being replaced. And the new program is going to be called the Part D Manufacturer Discount Program. So this new program is going to shift and around the cost burdens that the government, that's Medicare, covers, that manufacturers need to cover, what Part D plans also need to cover. And Chris, as you mentioned before, you and I typically think in terms of how this new cost structure and responsibilities impact the pharmaceutical manufacturers. But the Part D redesign also changes the responsibilities of plans. And in fact, it really increases what plans' responsibilities in the catastrophic phase are. It used to be a low 15%, and now it kind of goes up to 60%, which is quite a bit more. So Amanda, we're really curious, how are payers approaching these changes?
And Danny, so I think a lot of people walked away from the IRA and our side of the industry thinking, yes, manufacturers took a huge hit, and we did. And honestly, the IRA, I think, is the biggest win for patients, having an out-of-pocket max, being able to spread their out-of-pocket costs out over the year, like definitely a huge win for patients. But manufacturers, and especially Part D plans, they took a really big hit with this. And to them, you've basically, the way that their profits kind of align, their medical loss ratio, where they're able to balance the money that they make off the plans between premiums, the out-of-pocket payments that patients are making, we really just we're kind of squeezing the balloon and shifting things in other ways. So now that they have more liability at the pharmacy counter, how's everything going to change around that? So let's just focus on the pharmacy counter for now. Right now, what they want to do is, again, more of the same of just limiting what's going through the pharmacy counter. So again, we will see more utilization management. We'll see more step edits. I think we're going to start seeing even more, and the payers have told us we're going to be managing high cost rare disease products more than ever before. Their fingers are really in on making sure that patients are appropriately using high cost products, but sometimes on rare disease, it's not as heavy in terms of scrutiny of getting patients those products, because by the time they need it, they've gone through all those steps. But I think they're really going to get much more aggressive in terms of rare disease because there are so many different products coming out in those categories with very high price tags. So that's going to be a way that they're going to manage really that catastrophic spending that they're now liable for, is really looking into the way that they can kind of manage how patients get to that product. So one of the things that the plans will have to think about is if they want to move from, for example, a copay structure to a cost insurance structure or co-insurance. So where a patient may have been paying a flat amount for a drug, they may move to a percent cost share. But again, they're only getting to the point where the patient's now paying $2,000. So they really have to think about ways to manage the benefit. So I don't think we're going to see and they tell us we're not going to see a huge change in the way that the benefits design, the tiers, the products. It's just more the products on the formulary getting skinnied and them doing a heavier scrutiny of those. One other thing to point out, I think, with all of this is the phase in. So some manufacturers were able to receive these exemptions from either patients with a low income subsidy or overall that they were considered a small manufacturer. And because of that, they're not paying as much into the patient's out-of-pocket costs for a few years. And when that law came out, everybody was wondering who's going to pick up that amount. Is Medicare going to make that payment at the pharmacy counter? Who's liable? And it's turned out it's the payer. So now not only do you have the payers adding more of a liability now just under the new Part D design, but now for these companies that got these phase-in designations, they're also paying for those. And I think people thought getting this designation was going to be a great thing for their company because it's going to save them money on the front end or in terms of what they're paying at the pharmacy counter. But the payers are going to be coming back to those companies and asking for rebates because now they're losing a lot of money. So I think we've had just a lot of unintentional things happening here that I don't think people really thought through with this law, where you've now even created where some of these small companies, and there are large companies that got this designation as well, just based on the way that the designation was assigned. But these companies thought, oh, our pipeline's good. We've got rare disease products and we're a rare disease company. We're bringing these things in. Well, now they could really get hit by what the payers are going to be seeking for in terms of rebates that maybe they didn't have to pay out before. So just a lot of these things are going to just result in a lot of chaos for the payers at the pharmacy.
Yeah, maybe let me amplify that a little bit and talk a little bit about the phase and how this came about, right? So we are moving, like Danny said, from the existing coverage gap discount program where manufacturers were giving 70% discounts on prescriptions for patients in the coverage gap phase. Now we're moving to the new discount program that kicks in 2025, where the manufacturer is giving a 10% discount in the initial phase and then 20% in the catastrophic phase. And of course, financially, this ends up being a greater burden because 70% in the limited time period the patient's in the coverage gap is different from 10 and now 20% for the catastrophic phase, which extends all the way to the end of the plan year. And so in the law, Congress wrote in this phase-in opportunity so that for manufacturers that qualify for one of two buckets, the discounts don't kick in 2025 at 10 and 20%, but they kick in at a lower percentage and then go up over 7-8 years. So when Congress came up with that, it left open the question of where this essentially shortfall was supposed to come from. Because if the math is supposed to work out to 100% and 10% or 20% is assigned to the manufacturer, but now the manufacturer is being phased in and is paying only 1 or 2%, where is that other piece coming from? And so CMS, in its wisdom, decided to allocate that to the plans. And so exactly to your point, manufacturers that were happy about getting one of these two phase-in designations, the completely clear and not confusing terminology is specified manufacturer and specified small manufacturer, found themselves in this world where their reduced burden is pushed over onto the side of the plans, and obviously motivating the plans to try to get that back again from the manufacturer. So Amanda, another piece here that's also somewhat technical is this so-called smoothing or installments of allowing the Part D beneficiaries or the members in the Part D plans to spread their out-of-pocket costs over the entire plan year. So instead of paying these costs when they occur every month, now the plan members under the law are allowed to smooth these payments over the entire year. To me, that sounds like a significant administrative challenge for the plans. What did you hear from plans about implementation of this new approach?
Sure. So, yes, this is the Medicare prescription payment plan. I think smoothing was the term a lot of people were using originally. We're hearing N3P now, not to be confused with the MP3 player that many of us may have started with in the early digital days of yours. So, yes, the smoothing plan is really, again, another win for patients, especially if you're a patient who's on a high cost drug. You're going to hit that out of pocket cap in January. And even though the $2,000 out of pocket cap might be nicer than what it used to be with a 5% cost share and catastrophic, it's still a lot of money for a lot of patients. So to be able to spread that money out over a year, or if someone even is hit in June or July with a high cost drug, they can spread that out over the year. So I think it's definitely going to drive up adherence and utilization of products, which does concern the payers that we surveyed. As far as implementing the program, to them, they said, this just sounds like an administrative burden to us. It's going to be a huge pain at the pharmacy. Originally, they were going to have patients be able to sign up at the pharmacy in year one. We're not doing that. You just have to sign up during open enrollment online. So that is one thing that changed. But at the end of the day, first of all, the guidance from CMS came out kind of late on this. So payers haven't been able to really pull together their final plans. Just, July 17th, I think, or 16th was the day that we saw the last bit of guidance on how this was to be implemented. So CMS said, okay, if someone's considered likely to benefit with a $600 prescription, you need to notify them of the plan. And here's the language you can share with them. So payers, they don't really want this plan. I mean, this isn't great for them, right? If a patient isn't making their payments. So they told us, yeah, we're just doing what we have to do. That's it. We're going to do what CMS told us to do. The future we might make some materials, but they said specifically, we plan on manufacturers, providers, patient advocacy groups. We plan on them being the ones to really educate patients around this. And we're not going to do anything more than we really have to. And really, I can understand that, right? Their incentive isn't huge. One of the things we've kind of seen from this and from this information is a lot of our clients are starting to say, okay, what type of information should we put out for our patients? So what should we be sending from our hub? What should we be mailing out to patients? Should we be putting videos online? Should we be giving provider education tools? And, usually, we'll create something and we'll word it one way for providers' offices and one way for patients, but the doctors don't even really understand this. Their offices don't really understand this yet. So I think one consistent way that manufacturers can really get in touch is creating videos, creating letters, sending things out, keeping very consistent education materials between the provider audience and the patient audience, and then also working with patient advocacy groups to make sure that they're posting the information and sharing that with them, because everyone's scrambling now to educate patients about this before October.
That's super interesting, Amanda. And I guess to wrap things up, I believe the Magnolia survey also looked at some of the broader effects of the IRA on the industry. And I'm curious, what were some of the trends that payers identified, and what else do you think we can expect to see?
So, Danny, I would say one of the other things a lot of people are asking about is premiums. We saw this week there were some things that came out about how much premiums, the base beneficiary premiums, are going to soar, and that CMS just released a potential, goal to keep those controlled through a demonstration project. So I think there's a lot to be seen there. We did talk with the payers, and one of the great things about the survey, so we surveyed 23 payers, and then we also spoke with 11 actuaries and payer different people, and got ideas from them. So a pretty big group, but the actuaries gave us a lot of information on this piece of it. And really getting into, as I talked earlier about squeezing that balloon, you're losing money on one side, it's got to go to the other side. But at the end of the day, a Part D plan can only make as much money as the medical loss ratio allows. And the Part D plan itself isn't walking away with 15, 20% profits. These are like small, single digit profits. So because of that, they have to really make their money on enrollment, and they have to get as many healthy beneficiaries in as they can. So premiums are going to go up. The base premium calculation will go up. But what the plans actually will end up doing and how they'll react to that is to be seen, right? Because they have got to get these healthy patients in. They've got to make sure that they're managing costs by volume. So that's probably the biggest thing. I always look at, oh, well, everything's going to result in premiums. We knew premium stabilization was part of the IRA. That's going to help it, but we're all seeing that's actually a different calculation than we originally thought. And premiums could go up more than 6% for beneficiaries, but the plans have to be really smart around that to still be attractive. I do think Part D plans will suffer a bit more. That was another thing we talked about in the survey, is the future of the PDP versus the MAPD. It's definitely going to hurt them more, the way that their businesses and their profits and their rebates are structured. But at the end of the day, healthy enrollees is where you win on Medicare if you're a plan. And I will say again, the biggest thing that we're catching in these surveys is just the feelings throughout of how much this is hurting the payer and how much they plan on the manufacturer helping with that loss. And I know manufacturers are looking at it from how much the manufacturers are hurting from this and hoping that the payers are going to ease off. And every survey that we've done, the payers say, we're recognizing that manufacturers are going to be less willing to negotiate with us, but we're planning on still pushing for negotiation. So I think we have a lot of wrestling here that we're going to be doing. So maybe someone will pick that as their Olympic sport today, but there's definitely going to be a tug of war between the plans and the manufacturers from now on.
Well, thanks, Amanda, for walking us through that. Super helpful and insightful to understand what is happening on the payer side. I mean, one theme I'm hearing from all this is unintended consequences. So Congress dreamed up a brand new scheme here, and not sure we're even fully aware yet how it's all going to play out with unintended results. You mentioned the increase in premiums. It'll be fascinating to see how that kind of plays out. The other thing, of course, you just mentioned it, is this sort of reallocation of burdens. So the IRA itself, but now also CMS with, for example, how it's allocated the phase-in shortfall here, is really pitting key stakeholder groups against each other. And if we think which other federal program has that type of a setup, of course, it's 340B, and we kind of know how that's not working out so well. So take a look at the Magnolia public version of the survey. It's going to be on their website, and we'll have a link to that in the notes. And I think that takes us to the question we had asked at the beginning, which Olympic sport is this like? Amanda, do you want to go first and tell us what you think?
Sure. So I'm 6'1", so gymnastics was never something that I could excel at. But I would say I put this at the gymnastics level, although wrestling, it could definitely be wrestling. I would say for gymnastics, I think the IRA unfolding is absolutely exhilarating to watch, especially for people in policy circles. It's very complex. There's lots of twists and turns, different routines, different exercises they do. I always look at complete disbelief of the gymnastics athletes. I'm so nervous for them. I'm worried someone's going to fall or break a limb. And it never ceases to amaze me what they can do at the Olympics, just like our friendly federal government. So I would definitely say gymnastics.
I love that sport, especially with the recent victories of our hero Simone Biles in Paris. I myself was thinking of another unusual sport here, and surfing came to mind. The IRA is almost like a big wave, I think, right? Like the negotiation, the Part D redesign, the inflation rebates, and it's all coming in. And payers, manufacturers, CMS, everyone just kind of has to be ready to ride this wave, because ready or not, it's coming, and we have to ride that wave. And during the Paris Olympics, you may ask, where is the surfing competition happening? So it's actually in French Polynesia, which is about 10,000 miles away from Paris, but they got some of the heaviest, most powerful waves in the world, kind of like the IRA. So, Chris, I'm curious, what sport did you pick?
Well, I'm going to stay in Paris, and I'm going to pick the triathlon. And it's funny to me because you have to cycle 40 kilometers and run 10 kilometers. That's kind of like do clinical trials, get your drug approved, but then you're not done. The third piece is the 1,500-meter swim, which, as we know in Paris, is happening in the Seine right in Paris, which may or may not be healthy to dip into or not. But this whole IRA thing kind of occurred to me as similar to this whole process, right? It's a very torturous, very difficult race to go through. And at the very end, you got to swim in the polluted river, which is kind of the IRA forcing me to go through bunch of added things. So unfortunately, we're not in Paris, and so we'll have to host our after party stateside. But Danny, where are we going? Where are we hosting our party today?
Well, Chris, Amanda and I were talking right before we hopped on the recording, and we're both in the mood for lobster rolls. It's been a hot summer, and we're kind of feeling like going and to Luke's Lobster to enjoy some lobster rolls and a fresh lemonade or something like that. So if that sounds good to you, we can hop on over. It's only a few blocks from our office here.
It's a hot day in DC, and this sounds wonderful. I can't wait to go. Thanks to Amanda for joining us from Magnolia Market Access, and thanks to Danny for being a moderator.
Hey, thank you so much for having me.
It was great chatting with you both today, as always.
And thank you to our listeners for checking out the Latham & Watkins Drug Pricing Series, which is part of our Connected with Latham podcast. You can subscribe and listen to new and archived episodes of Latham's podcasts on lw.com, Apple Podcasts, Spotify, or anywhere else you listen to podcasts. If you have questions or would like additional information, please email us using the links located in the show description. We hope you'll join us again next time.
This podcast is provided as a service of Latham & Watkins LLP. Listening to this podcast does not create an attorney-client relationship between you and Latham & Watkins LLP, and you should not send confidential information to Latham & Watkins LLP. While we make every effort to assure that the content of this podcast is accurate, comprehensive, and current, we do not warrant or guarantee any of those things. And you may not rely on this podcast as a substitute for legal research and/or consulting a qualified attorney. Listening to this podcast is not a substitute for engaging a lawyer to advise you on your individual needs. Should you require legal advice on the issues covered in this podcast, please consult a qualified attorney. Under New York's Code of Professional Responsibility, portions of this communication contain attorney advertising. Prior results do not guarantee a similar outcome. Results depend upon a variety of factors unique to each representation. Please direct all inquiries regarding the conduct of Latham & Watkins attorneys under the New York's disciplinary rules to Latham & Watkins LLP, 1271 Avenue of the Americas, New York, New York, 10020. Phone number 1-212-906-1200.